This animated flowchart maps the diagnostic pathway for adult hyperbilirubinemia. The initial step requires splitting the condition into two distinct categories based entirely on laboratory data, unconjugated or conjugated bilirubin. If AST, ALT, and alkaline phosphatase remain within normal limits, the diagnostic field narrows immediately. We can isolate unconjugated etiologies, pointing directly to overproduction from hemolysis or a conjugation defect like Gilbert syndrome. A different picture emerges when hepatic enzymes are elevated. Here, the algorithm forces a second split. We have to identify the primary pattern of injury, an AST and ALT dominant spike indicating hepatocellular damage, or an alkaline phosphatase dominant pattern pointing to cholestatic disease. For the cholestatic, alkaline phosphatase dominant pattern, the immediate next step is anatomical. We order a right upper quadrant ultrasound to assess the biliary tree for dilation. The ultrasound results dictate the final pathway. Finding biliary dilation confirms an extrahepatic obstruction, requiring a procedure like an ERCP to relieve the blockage. A complete lack of dilation indicates intrahepatic cholestasis, driven by conditions like primary biliary cholangitis or drug toxicity. Relying on this specific pattern of enzyme elevation prevents unnecessary invasive procedures. The lab results determine the anatomical target, which dictates the definitive imaging pathway. Massive spikes in AST and ALT, often exceeding 1,000 units per liter, typically result from massive toxic or ischemic insults. The most common etiologies are acetaminophen overdose and ischemic hepatitis, also known as shock liver. These extreme enzyme elevations look alarming. They indicate severe hepatocellular death. But necrosis alone doesn't define failure. This diagnostic equation illustrates the critical threshold. An injury officially escalates to acute liver failure only when severe transaminase spikes are combined with a prolonged INR of 1.5 or greater and clinical signs of hepatic encephalopathy. For acetaminophen toxicity, immediate management requires N-acetylcysteine administration. If synthetic function declines and encephalopathy worsens, the patient must be referred for a liver transplant. Ischemic hepatitis operates differently. The massive transaminase spike is a secondary consequence of severe hypotension. Restoring perfusion and treating underlying systemic shock is the only way to halt hepatic necrosis. The liver has vast regenerative capacity. Transaminases measure the scale of the damage, but synthetic dysfunction and a failure to clear neurotoxins are the absolute markers of a failing organ. Managing chronic cirrhosis requires strict preventative maintenance. We start by treating the underlying viral or metabolic cause, enforcing absolute alcohol abstinence, avoiding hepatotoxic medications, and ensuring the patient is vaccinated against hepatitis A and B. For compensated cirrhosis, surveillance protocols are mandatory. Patients require an endoscopy to screen for esophageal varices, alongside a right upper quadrant ultrasound and an alpha-fetoprotein draw every 6 months to monitor for hepatocellular carcinoma. When a cirrhotic patient develops new-onset ascites, fluid accumulation must be categorized. This requires an immediate diagnostic paracentesis to extract and analyze the fluid. This visual details the SAG. Subtracting ascites albumin from serum albumin categorizes fluid shifts. The diagnostic threshold is 1.1. A SAG of 1.1 or greater confirms portal hypertension, dictating therapy: sodium restriction, then spironolactone and furosemide. Refractory fluid requires large volume paracentesis or TIPS. In these patients, ACE inhibitors, angiotensin receptor blockers, and NSAIDs are completely contraindicated. These medications blunt the renin-angiotensin-aldosterone system, severely worsening renal perfusion in a body already struggling with massive fluid shifts. Calculating the SAG is the definitive step that separates pressure-driven portal hypertension from low-protein states or malignancy. That single mathematical value determines the entire diuretic and interventional strategy. Decompensated cirrhosis presents with overlapping complications, frequently presenting as altered mental status. We begin the differentiation process by ruling out spontaneous bacterial peritonitis. SBP is an infection of the acidic fluid. The absolute diagnostic criterion is an acidic polymorphonuclear cell count of 250 per cubic millimeter or higher. Clinically, it presents as a distinct triad: abdominal pain, ascites, and altered mental status. This table maps SBP against hepatic encephalopathy. We check abdominal pain and ascites for SBP, but cross them out for HE. HE is an ammonia-driven nervous system disorder, provoked by GI bleeds, infection, hypovolemia, or TIPS. Treatment requires correcting triggers and administering lactulose or rifaximin. Hepatorenal syndrome is an entirely different mechanism. It is a severe, perfusion-driven renal failure triggered by extreme splanchnic vasodilation and advanced cirrhosis. Because the kidneys are hypoperfused but structurally intact, the diagnostic identifiers are highly specific: low fractional excretion of sodium, a bland urine sediment without casts, and, crucially, an absolute lack of renal improvement following IV fluid administration. Fluids will not reverse hepatorenal syndrome. The protocol requires IV albumin to expand volume, followed by splanchnic vasoconstrictors like midodrine or octreotide to force blood back into the renal arteries, while preparing the patient for an immediate liver transplant. SBP, hepatic encephalopathy, and hepatorenal syndrome can all cause a patient to decompensate rapidly. Isolating the correct pathology based on pain presentation, fluid analysis, and volume response prevents lethal mismanagement. Moving to the gallbladder, the diagnostic spectrum begins with benign biliary colic. This occurs when a gallstone temporarily lodges in the cystic duct. By definition, the pain resolves completely within 4 to 6 hours, and the patient exhibits no fever, no leukocytosis, and no systemic signs. If the stone remains impacted, simple colic escalates to acute cholecystitis. The clinical picture shifts to persistent right upper quadrant pain, localized inflammation, fever, leukocytosis, and a positive sonographic Murphy sign on ultrasound. Ultrasound is the first-line imaging modality. However, if the ultrasound results are equivocal, the mandatory backup plan is ordering a HIDA scan to definitively assess gallbladder filling and cystic duct patency. There are 2 high-risk variants of cholecystitis that present atypically. Acalculous cholecystitis occurs in critically ill ICU or trauma patients entirely without gallstones. Emphysematous cholecystitis occurs primarily in older diabetic males, driven by gas-forming organisms in the gallbladder wall, requiring emergent surgical resection. Acute cholangitis is an immediate emergency. It is a severe, ascending bacterial infection of the biliary tree, usually occurring behind an obstructing stone or structure in the common bile duct. The clinical markers for cholangitis are precise. Patients present with the Charcot triad: fever, jaundice, and right upper quadrant pain. In severe cases, this progresses to the Reynolds pentad, adding profound hypotension and altered mental status as the infection becomes systemic. The treatment protocol is aggressive. Patients require immediate empiric antibiotic coverage for enteric bacteria, followed by an ERCP to physically drain the biliary tree within 24 to 48 hours. Finally, we differentiate the 2 chronic autoimmune biliary diseases. Primary sclerosing cholangitis typically affects young men with ulcerative colitis and shows stricturing and beating on an MRCP. Primary biliary cholangitis usually affects middle-aged women and is diagnosed by the presence of anti-mitochondrial antibodies. Identifying the exact anatomical level and severity of a biliary obstruction determines the intervention. The clinical data dictates whether the patient requires simple observation, heavy antibiotics, or an emergency scope. Acute pancreatitis diagnosis requires 2 of 3 criteria: severe epigastric pain radiating to the back, lipase or amylase elevated 3 times normal, and characteristic inflammation on imaging. Next, to find the etiology, every patient requires an immediate ultrasound and comprehensive alcohol history. Secondary etiologies include severe hypertriglyceridemia and hypercalcemia. CT scans are not routinely ordered upon admission. They are reserved for unclear initial presentations or when suspected structural complications arise days later. The severity of the disease dictates the mortality risk. Pancreatitis escalates to severe status if the patient experiences continuous organ failure lasting beyond 48 hours, displays systemic inflammatory response syndrome, or shows evidence of third spacing via a rising BUN to creatinine ratio and elevated hematocrit. The massive release of pancreatic enzymes causes profound systemic vascular permeability. We must monitor for severe complications, including acute respiratory distress syndrome, necrotizing pancreatitis, and pancreatic pseudocysts, which are managed conservatively with observation unless they become symptomatic. Managing acute pancreatitis relies entirely on locating the root etiology early, and continuously monitoring lab markers of vascular permeability to anticipate and prevent systemic organ failure. Managing an acute upper gastrointestinal bleed requires a sequenced protocol that prioritizes volume resuscitation over immediate diagnostic procedures. This scale details strict hemoglobin transfusion thresholds. For stable patients, we withhold packed red blood cells until hemoglobin drops below 7 grams per deciliter. If the patient is hypotensive, actively bleeding, or experiencing acute coronary syndrome, the threshold shifts upward to 9 grams per deciliter. Before any scope is deployed, the airway must be secured. Elective endotracheal intubation is mandatory for any bleeding patient presenting with a depressed level of consciousness and active hematemesis to prevent fatal aspiration. Initial pharmacological stabilization utilizes high-dose proton pump inhibitors to stabilize clot formation in the stomach environment. Diagnostically, an elevated BUN to creatinine ratio is a classic rapid marker indicating the digestion of blood from an upper GI source. If a variceal bleed is suspected in a cirrhotic patient, the protocol becomes extremely aggressive. We establish 2 large-bore IVs, administer IV octreotide for splanchnic vasoconstriction, and push prophylactic antibiotics. Only after this sequence is complete does the gastroenterologist perform endoscopic band ligation. Surviving a severe gastrointestinal bleed is an algorithm of stabilization. Success requires securing the airway, hitting precise hemoglobin volume targets, and clamping splanchnic flow before an endoscope is ever inserted.